Welcome to the deep dive. Today, we're looking into something really fascinating. It's how the difficulties in medical imaging for patients with obesity are actually pushing innovation. We're not just talking about overcoming hurdles, but how these challenges are leading to some genuinely groundbreaking new treatments in medicine. It's quite a story of adaptation and science.
Absolutely. And for this deep dive, we've gone through a range of clinical reviews, medical reports, and expert consensus papers. Our goal here is really to give you a shortcut to understanding this pretty complex area where obesity and modern radiology meet. We want to highlight the clever ways healthcare is adapting, both for accurate diagnosis and even for offering new ways to treat these conditions.
Okay, let's start with the basics. The sheer number of people affected by obesity globally, that must create a huge challenge for imaging departments right from the start. What does that actually look like on the ground?
Oh, it's significant. I mean, obesity is a major global health issue, and it often comes with other conditions like type 2 diabetes, heart disease, even cancer. So more patients need imaging. But their physical size, well, that directly bumps up against the limits of the equipment.
Right.
Standard machines historically often had weight limits under 250 pounds. That's changing, thankfully. Newer equipment might go up to 500, maybe 700 pounds.
Yeah.
But it's still a major factor.
And it's not just the weight, is it? It's the actual physical space inside the scanner. I always find MRI machines a bit, close. I can only imagine if the opening is just, 70 centimeters normally?
Exactly that. That standard 70-centimeter aperture makes access tough. We are seeing newer bariatric gantries, maybe 85, 90 centimeters now, which is a big help for comfort and just, access. But even if the patient fits, there's another issue. Increased body thickness means the signals like X-rays or ultrasound waves get weakened or absorbed more. Attenuation, it's called. And that leads to more scatter, kind of like light bouncing around chaotically, more noise in the signal, and ultimately poorer image contrast. This happens across the board: radiography, CT, ultrasound, MRI.
So we're not just talking about a slightly fuzzy picture. This could actually affect the diagnosis, hide something important.
It absolutely can. Images might look hazy, potentially obscuring, say, small lesions or subtle changes in tissue. Think about a chest X-ray where something is missed, or the difficulty in getting good compression for a mammogram on larger breasts. It's a real challenge.
And what about the staff, the radiographers?
Yeah, they face practical problems too. Positioning patients correctly, finding bony landmarks through thicker tissue, just getting the whole area they need to see into the picture. There's also this thing called dose creep. Radiographers might sort of unconsciously increase the radiation dose, trying to get a clearer image, which isn't great long-term for the patient.
And we have to remember the patient's experience in all this. They're often very aware of their health situation, maybe feeling self-conscious. Compassion is key.
Definitely. But the exciting part is how healthcare is adapting. Manufacturers are responding with those higher capacity, wider bore machines we mentioned. But the real ingenuity, I think, is in the digital techniques and software that are helping to, clean up that noisy signal from thicker tissue.
So it's like digital signal processing, like noise cancellation for the body.
Sort of. Radiologists can now adjust settings like the X-ray energy, KVP, and the amount of radiation, MAs, more precisely for larger patients. And in MRI, there are clever tricks. Things like no-wrap options to avoid signal folding over, and saturation bands that basically tell the scanner to ignore the signal from fat outside the area of interest. This not only clears up the image, but can also improve safety, reducing the risk of skin burns if the patient is very close to the scanner wall.
Okay, so we're getting better pictures, but you mentioned this is also leading to new treatments. How does that work?
Right, this is where radiology steps beyond just diagnosis. One really novel area is bariatric embolization. It's minimally invasive. A radiologist guides a tiny catheter through blood vessels to the arteries, supplying a specific part of the stomach, the fundus. Then they inject tiny beads, microspheres, to block off some of that blood supply.
And the goal there is?
To reduce the production of ghrelin, the main hunger hormone, which is largely made in the fundus. And the results are promising. Studies looking at pooled data show an average weight loss around 8.11% from baseline after a year.
Wow, 8%. That's quite something for a minimally invasive procedure. Are there specific patients this is best suited for?
It seems particularly helpful for patients who might not be good candidates for traditional weight loss surgery. Maybe people with severe liver disease, like end-stage liver disease or NAFLD. It offers a targeted approach. And then there's another technique, cryovagotomy.
Cryofreezing.
Exactly. It uses needles through the skin percutaneous to apply extreme cold freezing to parts of the vagus nerve. The idea is to interrupt the nerve signals related to appetite that run between the stomach and the brain. Early pilot studies suggest it's feasible, seems safe, and patients do report feeling less hungry.
So radiology isn't just about taking pictures anymore. It's playing a much bigger role.
A much broader role. Diagnosing obesity-related issues, yes, but also monitoring weight loss progress, checking how bariatric surgery went, and even looking ahead to things like AI automatically analyzing body composition from scans.
It really shows how challenges like imaging difficulties here can spur incredible innovation. Healthcare is really showing its adaptability.
It really is. When faced with a problem like getting clear information from inside complex bodies, we often find these elegant, sometimes unexpected solutions.
So here's something to think about. Could these less invasive procedures, like embolization or cryovagotomy, born partly out of imaging needs, actually end up revolutionizing how we treat obesity itself? Could they offer real hope for millions who maybe can't or don't want to go the traditional surgery route?